Okay. I was just talking about Dr. Pradeep's recent publications. Out of a total 17 publications, a few, if I should name, in the year September 2017, he has published a study, Awareness and Compliance to Anti-Smoking Law in South Bangalore. And then another one, Multi-Analysis of Predictors of HIV Prevalence Among Pregnant Women in India, that is in 2015. Coverage and decline in HIV prevalence among female sex workers in South India in June 2014. 2 cross-sectional studies in South India assessing the effect of HIV prevention program for female sex workers on 2014. And the state South India using multi-level statistical modeling techniques, that is in 2013. This is in brief an introduction to our guest speaker, Dr. Pradeep. Once again, I thank you, Doctor, for joining at such a short notice. And to go ahead with the program today, I had shared with you a few of the talking points, which I'll briefly touch upon. One is we wanted to discuss the current COVID situation in India and Karnataka and the projections for the future. The reason why we were actually interested in this aspect of the COVID situation was that the group, the class BMC group, has been discussing the current COVID situation for quite some time and trying to come up with certain solutions or suggestions as to how we as a class or we as a group can actually contribute to handling it. To briefly introduce our classmates who are actually who are now online, quite a few of them have joined in from UK and the US, and many of them are from India, of course. And among the participants, there are a few of classmates who are out of practice of medicine, including me. I'm myself in the police though. But we have classmates in the IAS also. I think Manjula has joined. She's in the IAS in Karnataka cadre, and she's serving as MD of KPTCL. That apart, she's also in the thick of things as she's the nodal officer for management of COVID in the city of Bangalore. I think Manjula can maybe brief a little bit more of what exactly she's doing later on. And we also have another officer from Rajasthan cadre who is in the IAS, and Preetham, who couldn't join here. I think he's on election duty in Kerala. I requested him to join. He may join later on. Apart from these who are outside medicine, I think we have a whole batch who are very interested in actually to come out with some kind of interventions. But we didn't have any kind of a scientific model or a scientific way in which to decide how to go about and in what way to intervene and how to go about. And Vasu is one of our classmates. He's into he's running a couple of NGOs, and he's into field-related work. And he's the one who's actually the brain behind this entire webinar. And he wanted a webinar to be organized with experts speaking on the current situation of COVID and then the kind of interventions we can go ahead. Probably at the end of this webinar, maybe we can have something gelling out or some take home where we can decide as to how this class or how this group can actually come together and contribute to managing COVID here. So that is basically the intention behind calling you, Doctor, and having this discussion. So the topics that all of us put forward were probably you talking on the current COVID situation and projections for the future, and then probably some critical issues and possible solutions. Latest findings regarding viral potency and mutations and etc. And recent trends in the management of COVID, symptoms and monitoring at home, early signs of deterioration, management methods at home, myths and facts, and etc. etc. Vasu had some more points when I was discussing with him in the afternoon, that he wanted some scientific basis on which some studies have been conducted as to how the second wave is going to progress, and are we likely to have a third wave, and what would be its duration and maybe timing and other connected issues. So if anybody has to add something to what I said, please go ahead and add before I can ask Dr. Pradeep to take over the session and speak for some time. And once he has completed speaking, probably we can join in and have a discussion and raise some questions, and he'll have answers for them. Vasu, if this is okay, we'll go ahead.
Yeah,
You can
it's better
let
that
us know
Dr.
what.
Pradeep's. It's better that Dr. Pradeep starts, and then we can anyway ask questions and add after he speaks.
I totally understand. So that's what that is the pattern I thought. Dr. Pradeep, you're comfortable with this, that you take over the session for a few minutes. You can let us know broadly on these aspects, and then we'll take it forward with a discussion. Anybody else has anything to add at this moment? Okay, I'll take it that none of us have anything to add at this moment, and I'll request Dr. Pradeep to go ahead. Thank you, Dr.
Thank you, sir.
Please take over.
Thank you very much. And at the outset, I thank all of you for having me into this webinar. And it's very heartening that doctors across borders are volunteering to do something to the current ongoing pandemic within India. So, and all I can speak is some evidence which is already there, and the experience as a state technical advisory committee member. And since yesterday, we have had until today evening, we have had about 101 TAC meetings continuously ongoing since the last year. So with that experience and with some amount of epidemiology and public health experience, I would be talking to you based on the talking points which was provided. And I'm open for discussion, and I would also like to have questions either in between or at the end, however you feel it is comfortable for all of you. So in terms of the talking points, the first talking point which I've got is current COVID situation in India and Karnataka and the projections for the future. The current situation is both kind of not very heartening, but there are certain take-home points which are actually good and heartening as well. The thing is, Kerala and Maharashtra, especially Mumbai, and Tamil Nadu, especially Chennai, have already seen the plateauing of the second wave, and we see a downward trend happening there. And the situation in Karnataka, we feel that if not for the lockdown, we would have seen much more. And maybe we will peak at 50 to 60,000 per day and then come down. We have already reached 60,000 per day, and we have kind of plateaued, but maybe because this is a weekend and weekends are generally low numbers of testing positives. We don't know the reason why, but the number of tests is actually the same throughout, 1.5 to 1.5 lakhs, 1.6 lakhs every day. So what is heartening is the case fatality rate, which is hovering anywhere between 0.6 to 1% compared to other countries where it hovered between 15 to 35%. One, because of the demographics. Two, because of the vaccination drive which we have done. And most of those who are dying today in this second wave are those who are unvaccinated, and those who have delayed getting a test done, or those who have delayed testing a treatment done. And projections for the future, based on what our TAC members we have done, we would see a peak around, the peak has already started, and we would peak around May 11th or 12th, and then start the downward trend and end around end of June. That is what we feel, and that is what the projections are. We might see anywhere between up to about 16 to 17 lakhs totally, compared to totally counting both wave 1 and wave 2. And then there will be a kind of mellowed down epidemic, and probably there is a third wave happening around November, and during which time the strategy is to vaccinate as much as possible, number one. Two, try to instill COVID appropriate behavior as a new normal and go through it. At the same time, look at the evidence for vaccination among children, which is happening at certain places in different parts of the world. So we are awaiting those results and then see if children also can be vaccinated. But what history says is second wave is always the bigger wave in terms of mortality as well. But surprisingly, this time the mortality is low compared to the last time, mostly because we have set protocols. We have vaccinated people who are at risk of dying. At the same time, people know treatment and they are starting treatment even with without getting tested. Although it is not appropriate, but it is in a way saving us as well. That's our experience in terms of projection for the future. So in terms of the next points, current critical issues and possible solutions. So current critical issue is the number of cases, the number of availability of beds, and number of people seeking oxygen. Most of it is, as per our understanding, those who are on non-oxygenated beds or those who don't need oxygenated beds. Those who are on normal beds, I could say. So out of the 100 who are occupying the beds, about 70% can be at home. That is our assessment. And out of the HDU or the oxygenated beds which are occupied, around 60 to 70% need not be in oxygenated beds. And out of about people who are in ICU, about 40 to 60% need not be in the ICU. So basically those beds are clogged because of panic which has struck and mostly because people want to go there, lie down because of want of beds if they need in the future. Mostly a panic or an anxious response for what is happening around. And I would say the WhatsApp University and also the media has played a role into it. So that's one of the reasons. That's a critical issue. And possible solution is kind of getting into I want to say these rumor channels through appropriate IEC and then get people do what they need to do. Basically looking at oxygen saturation and another problem is now. So anybody who is COVID positive, they get into HRCT, they get into Corat score, CT severity score, and start bugging BBMP or start bugging doctors around to whether they need to start things. And everybody knows what the treatment protocol is, and everybody tries to seek multiple people. So apart from the care component, this is the sociological component and the psychological component which needs to be addressed as well. So this, according to me, oxygen is an issue, but it might ease out this week because there is a lot of production increase and industrial oxygen. Many of you might know who are in the government and who are in services cadre will know that industrial oxygen is also routed for treatment, and there is allocation, both central and statewide allocation. Another critical issue is remdesivir. Yesterday, as far as I know, there have been about 80,000 doses which have been coming, and now which has come, and now it has been eased out and quite channelized. And people need to know that there is no way remdesivir can be procured outside of government system and outside of the drug controller management, and they don't just know. And even our doctors are trying to tell people that yes, it might be available, try to search a black market and things like that. And another thing is oxygen concentrators. And every third house in Bangalore either has an oxygen concentrator or have placed an oxygen concentrator, the order for an oxygen concentrator. These are all panic situation. Maybe I'm giving you a different perspective, but I think those are all things which could be addressed being in the US or being in UK or anywhere in the world or sitting at home within India. We can actually have a Moj video or a TikTok video if it is available, and then post it, or in YouTube video, post it, make it viral and make people aware that what they are going through or what they are wanting to is actually not needed. And I have heard people looking for oxygen concentrator and prices quoted at 1.3, 1.5 lakh, and I don't think it is needed at all. So basically, that is something which needs to be organized. So in terms of treatment, I think the protocols are all set. Most of the treatment is as per national protocols, which is in line with international protocols. Here and there might be some deviation. But so far, compared to the last wave, we are more equipped. And we know that ICUs are not the answer. Oxygen supply, nasal cannulas, oxygen concentrators are answers. And we need to prioritize on whom we are going to treat and whom we are going to treat in ICU. That's the discussion we had today. There might be some protocols and SOPs which might come today as well. So in terms of issues, these are the things. Food is not an issue. Lockdown might extend. As far as my epidemiological knowledge goes, I think another 2 weeks of extension of lockdown with some lenience to certain things would be a possible solution as well. Critical issue, another critical issue is we can establish ICUs and start it going, but where is the human resource is a critical issue. If people in the Western world who can provide time for telemonitoring or who can provide time of teleconsultation for people who are mild and moderate, that itself is an would be a possible solution also. So I can take more questions as well in terms of critical issues, because these are the things which come to my mind now. Going to the next point, latest findings, viral potency, mutations, etc. See, we at NIMANS do this mutation genomic gene sequencing of the virus and look at what mutations are happening. See, as the media projects, we have the original COVID virus strain that is there. There are some mutations which has happened in within India as well. And there is this South African variant, the UK variant, and the Brazil variant as well. Brazil variant is too low. There is the South African variant and the UK variant as well. But in terms of potency of the original virus, it has retained the same. There is it has neither increased nor decreased. It has retained its potency. The two mutants which I'm quoting, the UK variant and the South African variant, and also the Indian variants are more transmissible now. And the data doesn't support that. And these viruses and mutations, fortunately, against this UK variant as well, and to an extent Brazil variant also. And but deliberately that evidence has not been circulated too much, because there might be over or higher demand for Covishield and things like that. There is a whole lot of what to say, vaccine lobby and things like that which might come in. So it is deliberately kept on low profile, I think. And recent trends in management treatment options, budesonide has been added onto the mild or moderate management of continue to use. Tocilizumab, there is recent evidence that it is helpful, but not much utilized currently. But the management, the mainstay of management stays the doxy has been added on, and well, that is home is basically, see if they get anosmia and loss of taste, then we are treading on a trend shows. And two is an early indicator for people getting into lowered saturation. So I would suggest two things to be monitored. One is temperature, onset of new symptom, mostly cough, and then oxygen saturation. And there is no need to panic until the saturation goes down below 90. As below 94, but somehow that has gone, the message has gone so that they say once it is below 94, they need to get get admitted and need an oxygenated bed. And I think that is something is critical to look at in terms of clogging beds at different parts of the city as well. And treatment options, it remains the same. Some of them are using oseltamivir, but there is no evidence. Remdesivir is the only mainstay for antiviral. Otherwise, until it goes to that stage, between moderate to severe, I don't think remdesivir has a stay. I would suggest doxycycline, ivermectin is something which needs to be given along with symptomatic treatment. So that is something which needs to be monitored at home. And as we see, cough is usually occurring after 5th or 6th day of temperature. So if we can give symptomatic treatment like levocetirizine and to an extent N-acetylcysteine, Mucinex or Levonac, I'm not Levonac, or some trade names are there. So N-acetylcysteine is very helpful, and in terms of some bronchodilators also might help. So those are the things which needs to be monitored. Early signs of deterioration is oxygen saturation levels. Cough onset, they need to, I personally feel they need to monitor oxygen saturation. There is a new thing which we have added also, which is called the 6-minute walk test. Most of you will be knowing. So that's an early indicator even before the CT is done. So CT, instead of being done on the 1st or 2nd day of testing positive, if it can be done on 5th or 6th day, that's a much better indicator of lung involvement, because lung involvement starts usually during the 2nd week. So early signs to look at would be, I would say, symptom as cough, signs is saturation, and 6-minute walk test would be a good indicator of future involvement of lung and also some amount of cytokine storm. So that is something as management methods at home. Good to do pranayama, good to sleep using prone position. If such such videos can be made and made viral, that would be a good addition for or good value addition for the already going ongoing things. And one thing which we are also forgetting is post-COVID care. Post-COVID care is something everybody is ignoring. There is post-COVID arthralgia, which many people complain about, and there is what is called as long COVID in terms of psychologically or mentally there might be some kind of mental clouding, things like that, for which only Nimans is working. Not many physicians are confident or conversant about it. Something to that effect, if there is an intervention, it would be good, because currently in this kind of a number of cases getting in, everybody is focused on managing current cases. But if we can look ahead and then see what can be done, that is something which nobody is looking at right now. So that is something which we can look at as possible intervention or management methods at home. And in terms of if we can get videos on in local language, Kannadadalli, if we can get in like how to check for oxygen saturation, how to see whether the oximeter is correct or not, how to check temperature and things like that, or how to do a 6-minute walk test, how to sleep, how to do proning and things like that. It would be of lot of help, of value as well. And in terms of myths and facts, that's the last point which I have got as talking points. There are a lot of myths. Remdesivir is not available. Remdesivir needs to be given to every patient. Every patient has become a doctor themselves, and there is doctor shopping also happening. One doctor would have written a prescription. They would be in a hospital. They would be consulting 3 more people around, and lot of things going on. And one thing which we have observed also is, after this, these drugs are given about 5th or 6th day, they kind of become very fatigued and things like that. So they have this burning sensation in the eye, the lot of what to say, things which were not very kind of ನಂಗೆ ಗೊತ್ತಾಗ್ತಿಲ್ಲ, ಏನೋ ಆಗ್ತಿದೆ ಅಂತ ಹೇಳ್ತಾರಲ್ಲ, ಐ ಡೋಂಟ್ ನೋ ದ ಇಂಗ್ಲಿಷ್ ವರ್ಡ್ ಫಾರ್ ಇಟ್. ಸೊ ಏನೋ ಆಗ್ತಿದೆ ಡಾಕ್ಟ್ರೆ ಗೊತ್ತಾಗ್ತಿಲ್ಲ ಅಂತ. Most of them, if you give them ranitidine or pantoprazole, recover. ನಿದ್ದೆ ಬರಲ್ಲ ಅಂತ ಹೇಳ್ತಾರೆ. These things are some things which needs to be given as a tip to treating doctors also. But ಏನ್ ಮಾಡ್ತಾರೆ, doctors are also misled. They call it pancreatitis because of prednisolone ಅಥವಾ hydrocortisone ಕೊಡ್ತಾ ಇರೋದ್ರಿಂದ there might be some shoot up in the sugar levels also. So ಏನ್ ಮಾಡ್ಬಿಡ್ತಾರೆ, they are misdiagnosing as pancreatitis and then treating them for pancreatitis, IV fluids ಹಾಕ್ತಾರೆ. Instead, if they can put in on ranitidine or pantoprazole or something anti-gastritis ಗೆ ಕೊಟ್ರೆ, proton pump inhibitors or H2 blockers, that is something which we are seeing patient recover. But myth is ಸುಸ್ತಾಗ್ತಿದ್ದಾರೆ ಅಂದ್ರೆ they feel they are having low oxygen saturation and they panic, and it kind of viciously make them anxious or get them into a panic mode, search for people, hospital beds and things like that. Myths ತುಂಬಾ ಇಲ್ಲ, and waiting ಈ media ಅದು ಸ್ವಲ್ಪ ಇದರಿಂದಾನು ಇನ್ಫ್ಲೂಯೆನ್ಸ್ ಆಗ್ತಾರೆ. ಏನೋ ಬಂದ್ಬಿಟ್ಟಿದೆ ಅಂತಾರೆ, ಕೋವ್ಯಾಕ್ಸಿನ್ ಕೋವಿಶೀಲ್ಡ್ ಮಧ್ಯೆ ವಿಚ್ ಇಸ್ ಬೆಟರ್ ಅಂತಾರೆ. As far as we know, both are as effective. In fact, Covishield mutant strains, so there is recent evidence that it is working. So all these are happening. So myths and facts, if you can ask me whether this is a myth or a fact, I can tell you. But offhand, it is very difficult to list them out. But vaccine related ತುಂಬಾ myths ಇದಾವೆ. ಏನೋ ಬಂದ್ಬಿಡುತ್ತೆ, ಏನೋ ಇದಾಗತ್ತೆ, ಆಮೇಲೆ ಬ್ಲಡ್ ಡೊನೇಷನ್ 6 months ತನಕ ಕೊಡಕ್ಕಾಗಲ್ಲ post vaccination, whereas the actual fact is about 4 weeks wait ಮಾಡಿ ಅಂತ ಹೇಳ್ತಾರೆ. And there are myths like those who are vaccinated and have antibodies can give plasma ಅಂತ ಹೇಳ್ತಾರೆ. But that's not true. Only those who have naturally infected with COVID can donate plasma. These things are certain things which are myths with related to COVID vaccination and plasma. So I would stop here and stop bugging you all, so I can take questions and we can.
Thank you, Dr. Pradeep. It was quite exhaustive. on
Yeah.
the points that were suggested. I can see that Vijay has raised his hand. Vijay, would you want to speak?
Yeah.
Go ahead.
First of all, Vasu and Subbu, thank you for organizing this. And Pradeep, thank you very much for talking. And that was very, very useful. I work in England and I've been heavily involved with COVID management in the first wave here. And I am doing a telephone consultation to my family and friends in India. The general common trend we are seeing is a lot of people have been asked to have CT scans very early, as you were saying. And that's something that's got to change, number one. Number two, once they have been tested positive and they've been treated, they've been asked to have COVID tests repeatedly. I don't understand the rationale behind that because we don't do them here. And children have been also asked to have CT scans. That's a lot of radiation for children. And I don't see the benefit in seating them if they don't have any symptoms. Now, I'm not, and as you said, WhatsApp syndrome going on. To educate, do this and do that, and clarifying the myths and facts. That's one question. Second question is, in terms of remdesivir, again, evidence is very limited from what we have seen. I think the two major thinners, and remdesivir was a big deal. So what do you think should be, and the most important thing is when we advise people on telephones, we can do a lot and we can support them psychologically. We have been talking to them, all these things you mentioned about anxiety, lack of sleep at night, now we are dealing with that. The only issue I have personally is if somebody becomes unwell and they need hospital admission, that is where I am helpless to direct them to a place to go and get admitted. Until then, until the time they're at home and they're okay, we can support them and advise them with treatments and stuff, do a telephone consultation. But beyond that, that is where we are helpless because we are not linked to any hospital in India. Whichever.
Yeah, I agree with you, sir. And HRCT is something which has become a very difficult thing for us to handle. Through the technical advisory committee and the government as well, there is a lot of IEC material which has come out, and there are a lot of things which we are doing it. But unfortunately, the media is not projecting it. The media wants to sensationalize, and WhatsApp University picks up things from different parts of the world, and they just post it unverified. That is something which I don't think any government, any individual, anybody can handle. In terms of, it can be handled, but cannot be handled right away because our priorities are different and our priorities are focused on management of cases. In terms of bed availability, somehow people think their representatives, electoral representatives are ಯಾರೋ ರಾಜಕೀಯದವರು ಬೆಡ್ ಕೊಡಿಸ್ಬಿಡಕ್ಕಾಗತ್ತೆ ಅನ್ನೋ ಇದರಲ್ಲೇ ಇನ್ನೂ ತಲೆಯಲ್ಲಿದೆ. But as far as I know, the BBMP has in its portal quite an efficient this thing. I'm not telling you it is very, very efficient, but it is quite efficient given the situation and given the number of this thing. I agree that there was a problem 1 week back or 2 weeks back. Now it is slowly easing out. There are talks on where to establish multiple things. Many people don't know that there is a 500 bed CCC which is set up within Koramangala Indoor Stadium. And last week it was like 200 beds vacant, and now it is filled. We still have beds there. And there are NGOs and people who are doing a lot in terms of managing mild cases also to allay this anxiety. But bed availability is something which panic model ಮಾಡಿದಾಗ, when they call the BBMP and ask them, sir, ಏನೇನಿದೆ ಅಂತ ನೋಡಿದ್ಮೇಲೆ, if the saturation is 96, if they are below 50 years, no comorbidities, ಜ್ವರ ಸ್ವಲ್ಪ ಕೆಮ್ಮಿದೆ ಅಂದ್ರೂ they want a bed. And ಇದನ್ನ how can BBMP manage or anybody manage? Even you as a doctor, if you tell them, they won't agree. They will say, ಇವ್ರು ಹೇಳ್ತಾನಪ್ಪ, ನನಗ್ ನನ್ ಜೀವ ಒಂದೇ, ನಾನೆಲ್ಲ ಹೋಗ್ಲಿ, ನನ್ಗೇನಾರಾದ್ರೆ I will go sleep in a hospital ಅಂತ. So how much ever you tell them, this happens. ಸೊ ಇದು ತುಂಬಾ ಆಗಿದೆ, ಈಗ ಸ್ಟ್ರೀಮ್ ಲೈನ್ ಆಗ್ತಿದೆ. ಸೊ ಥಿಂಗ್ಸ್ ವಿಲ್ ಈಸ್ ಔಟ್. ಟ್ರಯಾಜಿಂಗು ಅಷ್ಟೇ, ಈಗ ನಾವು ICUಗಾಗ್ಲಿ ಆಕ್ಸಿಜನೇಟೆಡ್ ಬೆಡ್ಸ್ ಆಗ್ಲಿ, we are in a war footing. We are trying to triage like elderly 90 years, 95 years ge, we are saying we will only ask them to at the most get oxygenated, not to an ICU bed, because we want to save more people with NIV, because mechanical ventilation is known to have severe fatalities with COVID for unknown reasons. That's the evidence. So NIV, we are pushing more people who are young, who are lone breadwinners of the family. This is kind of a decision which is taken by the intensivist and the physician treating. Remdesivir ashte, it is very ontara ellu ಆಗ್ತಿಲ್ಲ ಇದೇನೋ, it is kind of we are not able to manage ಅಂದಾಗ remdesivir ಕೊಡ್ತಿದ್ದಾರೆ. Some of them are ಒಂಥರ turning around the corner after third dose of remdesivir, and I am one of those. Last wave al remdesivir actually helped me, and tocilizumab ಕೊಟ್ಟಿದ್ರು, but tosiಗೆ there is evidence currently, but there is not enough doses. One of the reasons why remdesivir shortage ಇರೋದಕ್ಕೆ ಕಾರಣ, see December ಅಲ್ಲಿ fully flatten ಆಗೋಯ್ತು ಇಂಡಿಯಾ ಪೂರ್ತಿ ವೇವ್, and short shelf life ಇರೋದ್ರಿಂದ remdesivir 3 months ಇರೋದ್ರಿಂದ manufacturing was stopped and exporting was done. So first ಏನ್ ಮಾಡಿದ್ವಿ ಈ ಪೀಕ್ ಅಲ್ಲಿ ನಾವು, we just stopped exporting and routed remdesivir for Indian patients. ಈಗ with lot of production increasing, next week it is already eased from yesterday. So ಈಗ you might see that as an effect. Indicator ಏನು ಅಂದ್ರೆ, you will stop receiving calls from people, remdesivir ಸಿಕ್ತಿಲ್ಲ ಏನ್ ಮಾಡೋದು ಅನ್ನೋದನ್ನ stop. I already got, there are no calls requesting for remdesivir since today morning. Not a single call today about remdesivir, whereas yesterday I used to get about 5 to 8 calls. So ಈ ತರ remdesivir has eased out. Hange oxygen will ease out because liquid oxygen plants have been established in each district hospital, and there are liquid oxygen plants set up within the BBMP zone only. There are 5 hospitals, Yelahanka, Shivaji Nagara, ilella ಒಂದೊಂದು MP ಕಾನ್ಸ್ಟಿಟ್ಯೂಯೆನ್ಸಿಗೂ MLA ಕಾನ್ಸ್ಟಿಟ್ಯೂಯೆನ್ಸಿ ಅನ್ಸುತ್ತೆ, ಅಲ್ಲಿಗೆ there is a 100-bed multi-speciality hospital which has come up, and those beds will be utilized from now on, from today, so from tomorrow. So ಅದನ್ನ ಲೋ ಪ್ರೊಫೈಲ್ ಅಲ್ಲಿ ಇಟ್ಟಿರೋ ರೀಸನ್ ಏನು ಅಂದ್ರೆ, ಎಲ್ಲರೂ ಬಂದು ತುಂಬ್ತಾರೆ. So BBMP will start allocating from tomorrow. So these are things which are happening, and system allu we have been wrong at times. Lockdown should have been 15 days back, and we should have started remdesivir production. ಇದೆಲ್ಲ ಆಗುತ್ತೆ because the system also, ಈಗ ಏನಾಗುತ್ತೆ, the same opposition will talk. ಏನಕ್ಕೆ ಮುಂಬೈಯಲ್ಲಿ ಈಗ ಶುರು ಮಾಡಿದ್ದಾರೆ, ನೀವ್ ಯಾಕೆ ಅರ್ಲಿ ಮಾಡ್ತೀರಿ ಅಂತಾರೆ. ಡಿಲೇ ಮಾಡಿದ್ರೆ ಮುಂಬೈಯಲ್ಲಿ ಮಾಡಿದ್ದು ನೋಡ್ಕೊಂಡು ಮುಂಚೆನೆ ಮಾಡಕ್ ಆಗ್ತಿರ್ಲಿಲ್ಲ. ಸರ್, ದೇರ್ ಇಸ್ ಆಲ್ವೇಸ್ ದಿಸ್. ಈಗ ನಾವು ಮದುವೆ ಮಾಡೋ ಹೆಣ್ಮಗಳ ತಂದೆ ಆ ತರ ಆಗ್ಬಿಟ್ಟಿರ್ತೀವಿ. ಸೊ ಬೀಯಿಂಗ್ ಅಟ್ ದ ಹೆಲ್ಮ್ ಆಫ್ ಅಫೇರ್ಸ್, we have to take the bricks and the bat also. So this happens. So that's my take on it. Children going for HRCT is a concern, and there is a government order which is coming up. Unless there is a pediatrician request or a prescription, no HRCT, and there needs to be a real need or indication for HRCT thorax for children also, and there will be designated HRCT centers for children from next week. So that's the thing which the government can do. Other than that, there will be pilferages here and there, deviations.
Thank you.
Thank you, Doctor. And Vasu, I think, has raised his hand. Vasu wanted to speak.
Yeah, thanks a lot.
Can.
Yeah, thanks a lot, Dr. Pradeep. Actually, I'm very happy that a person who's in technical advisory committee, we are able to invite you. And my questions are, there are many questions, but I'll just limit it to 3 now. Can we get rough projections for Karnataka, Bangalore, and other districts for the next few months? Because
Sir,
that
can
will
we get what? Can we get?
rough projections of cases for Karnataka, Bangalore, and other districts for the next few months, because that will help us to plan something. I mean, that will help you to plan something, but it may also help us working in the field to put up some campaign and also focus on where the caseload is more. Second one, according to me, this question I'm raising again and again, but there's no satisfactory answer. What is the possibility of reinfection? Because there's not much evidence that reinfection is I mean, there's high possibility of reinfection. I have not come across all that. Basically, even in hospitals, there's less manpower. There's short of human resources so much. Also because more than 60, I mean, people who are 60 plus are not turning up, and there's less staff in every hospital, even the corporate hospital. So if we can come to some conclusion about it, then many people who have had this infection earlier can freely, at least in the hospitals, if not, if you may not advocate it for the entire population, but at least the medical community. And third question is, what do you think that can we as a medical community do in this time, apart from doing individual medical practitioners? So these are the three things that I just.
Yes, sir. To answer the first question, which was on, I forgot.
Projections in the different
projections for
districts.
every district. We have got that projection, sir. And every district ಈಗ gross ಆಗಿ ಹೇಳ್ಬೇಕು ಅಂದ್ರೆ there will be about 10% more daily cases. That is when we peak anta projection. Say for example, if we are looking at 22,000 cases in Bangalore, the peak will be around 25 to 28,000, and then we come down, provided we have lockdowns. Okay. And again, about 10 to 20% will be the peak, and then it comes down. Another is the projection, which is a conservative estimate. Conservative in the sense kadame antalla. The largest which could happen is about 20%. 10 to 20% is what I could say. And it will peak around May 11th is what we see. But around 15th, 11th to 15th is when we peak. And then we start plateauing and come down. And by July end, it will be at the level of what we had in November. So that's how it works. Afterwards, there will be a lull period of about 3 months, and then again October, November, we might see surge in cases. But the third wave will, for all practical purposes, will be a mild one. Because if we can protect our children, that's it. We will be able to manage that crisis. That is what we feel. I hope and I am optimistic that I will be correct, or rather we will be correct in terms of projections. Second question is on reinfection. Reinfection is very, very, very minimal. And I think out of the thousands of cases which we are getting, it will only be in hundreds. That is what I am told. And actual data we don't know. And in terms of getting in doctors who have been infected, I will add to that, there is an order from the government that those who are infected as well as vaccinated and beyond 50 years, they are okay to come and do duties, and they are doing duties now. And at the same time, reinfection, if at all it is there, it is very mild, restricted to some kind of sore throat or some mild fever and loss of taste and smell. Beyond that, we have not seen anybody getting into even moderate or severe kind of disease. So that's the good point with reinfection. But we have data and we have information that there is reinfection. And the third point was, sir, third point?
No, apart from being individual medical practitioners, what we as medical community
ಸರ್ ಇದನ್ನ ನಮ್ಮ ಬ್ಯಾಚ್ ಅಲ್ಲೂ 93 ಬ್ಯಾಚ್ ನಾವು ವಿ ಥಾಟ್ ಅಬೌಟ್ ಇಟ್ ಲಾಸ್ಟ್ 1 week ಇಂದ ಮಾತಾಡಿ ವಿ ಆಸ್ ಎ ಗ್ರೂಪ್ ಶುಡ್ ಪುಲ್ ಇನ್ ಮನಿ ಬೈ ಕಾನ್ಸಂಟ್ರೇಟರ್ಸ್ ಅಂಡ್ ಡೂ ಥಿಂಗ್ಸ್ ಅಂತ ಅನ್ಕೊಂಡ್ವಿ. ಬಟ್ ಇಟ್ಸ್ ಗೋಯಿಂಗ್ ಟು ಬಿ ಎ ಬಿಗ್ ಆರ್ಡಿಯಲ್. ಸೊ ಇಟ್ ಈಸ್ ಬೆಟರ್ ಟು ಜಾಯಿನ್ ಆಲ್ರೆಡಿ ಎಸ್ಟಾಬ್ಲಿಷ್ಡ್ ಪೀಪಲ್ ಅಂತ ನಿರ್ಧಾರಕ್ಕೆ ಬಂದಿದ್ದೀವಿ. ಒಂದು ಈ ಸ್ಟೆಪ್ 1, ಡಾಕ್ ಪ್ಲಸ್, ಈ ತರ ಸುಮಾರು ಪ್ಲಾಟ್ಫಾರ್ಮ್ಸ್ ಇದೆ ಸರ್. ಇಫ್ ವಿ ಕ್ಯಾನ್ ಜಾಯಿನ್ ಹ್ಯಾಂಡ್ಸ್ ವಿತ್ ದೆಮ್ and do that, that is the most feasible ಅಂತ ನಾನು ಅನ್ಕೋತಾ ಇದ್ದೀನಿ. That is 1. 2, ಈ PM cares fund, CM relief fund ಗೆ ದುಡ್ಡು ಕೊಡೋದು. Many of them might not believe that it is good and it is not very, ಇದು ನಮಗ್ ಬೇಕಾದವ್ರಿಗೆ ಸಿಗಲ್ಲ ಅಂತ ಅನ್ನೋದು ಇದೆ. 3ನೇದು, if you have some kind of a trust and where you can get in money, that can be ಇದು resources. ಆಕ್ಸಿಜನ್ ಇಂಪ್ರೂವ್ಮೆಂಟ್ ಗೆ ಏನ್ ಮಾಡಬಹುದು, ದಟ್ ಕ್ಯಾನ್ ಬಿ ಲುಕ್ಡ್ ಅಟ್. ವ್ಯಾಕ್ಸಿನ್ ಡೆಲಿವರಿಗೆ ಇಫ್ ಯು ಕ್ಯಾನ್ ಡೂ ಸರ್ಟನ್ ಥಿಂಗ್ಸ್. ಡೆಲಿವರಿಗೆ ವಿ ಕಾಂಟ್, ಸ್ಟಾಕ್ಸ್ ಗೆ ಇದಕ್ಕೆ ವಿ ಕಾಂಟ್ ಹೆಲ್ಪ್. ಇಟ್ ಈಸ್ ಕಂಪ್ಲೀಟ್ಲಿ ಸೆಂಟ್ರಲೈಸ್ಡ್ ಅಂಡ್ ಇಟ್ ವಿಲ್ ಬಿ ಡನ್ at the level of the state central government, and that we can't help. So as a group of doctors, if you can volunteer and start doing teleconsultation, that will be a good start point. So if you can send in ventilators to medical colleges which are eager opening up to COVID care from government, ido in terms of ICU increase ಮಾಡ್ತೀವಿ ಅಂತ. Government needs ICUs and that is what their focus is on. And if you can donate ICUs, if you can donate nasal cannulas, high flow cannulas, if you can donate concentrators to hospitals, not for individuals, that would be a good thing anta ನನಗೆ ಅನ್ಸುತ್ತೆ ಸರ್. Post COVID care ಅಲ್ಲಿ if you can teleconsult, ಅದನ್ನ ಆಫ್ ಮಾಡೋದೇ, that is something which you can do. If some people can come down to India and then work, that's another thing which you can also participate. Because ಈಗ ಏನಾಗ್ತಿದೆ, ಡಾಕ್ಟರ್ಸ್ ಇದ್ರೂನು ಸ್ಟಾಫ್ ನರ್ಸಸ್ ಇದ್ರೂನು ಸುಮಾರು ಬರ್ನ್ಔಟ್ ಇಶ್ಯೂಸ್ ಆಗ್ತಿದೆ. ಸಮ್ ಆಫ್ ದೆಮ್ ಆರ್ ಗೆಟಿಂಗ್ ಇನ್ಫೆಕ್ಟೆಡ್ ಆಲ್ಸೋ. ದಟ್ ಈಸ್ ಸಮಥಿಂಗ್ ಇದು. ಆಮೇಲೆ ವಿಚ್ ಯು ಕ್ಯಾನ್ ಕಾಂಟ್ರಿಬ್ಯೂಟ್ ದಟ್ ವೇ ಆಸ್ ವೆಲ್. ಐ ಆಮ್ ನಾಟ್ ಶೂರ್ ಹೌ ಪಾಸಿಬಲ್ ಇಟ್ ಈಸ್. ಸೊ ಐ ಆಮ್ ಜಸ್ಟ್ ಗಿವಿಂಗ್ ಯು ಐಡಿಯಾಸ್ ವಿಚ್ ವಿ ಹ್ಯಾವ್ ಬ್ರೈನ್ ಸ್ಟಾರ್ಮ್ಡ್ ಲಾಸ್ಟ್ ವೀಕ್. ಸೊ ನಾವೇನ್ ಮಾಡಿದೀವಿ, ನಮ್ಮ ಗುಂಪಿಂದ, ನಮ್ಮ ಬ್ಯಾಚ್ ಇಂದ, ವಿ ಹ್ಯಾವ್ ಕೈಂಡ್ ಆಫ್ ಡೆವಲಪ್ಡ್ ಎ ರೋಸ್ಟರ್. ಸೊ 24/7, at least to people whom we know, our extended families and friends. ನಮ್ಮ ಪೂಲಲ್ಲಿ ಈಗ ನಮ್ಮ ಬ್ಯಾಚ್ ಅಲ್ಲಿ 250 ಜನ ಇದ್ರೆ, at least 5 families if we can contribute. And there is a lot of people who are handling individually also. That can be connected and rooster system al madadre, that would be a good thing. Psychological management too is also something which people can look at. So ಈ currently ನಿಮ್ಯಾನ್ಸ್ ಒಂದು ಹೆಲ್ಪ್ ಲೈನ್ ಇದೆ, ಅದೊಂದು 10 lines ಇದೆ which will be busy throughout 24/7. ಅದು ಬಿಟ್ರೆ ಬೇರೆ ಏನು ಹೆಚ್ಚಿಗೆ ನಡೀತಿಲ್ಲ. That is something which you can contribute also. Money is there, but where to put in ಅನ್ನೋದಕ್ಕೆ ICU is not a good bet, because ICU management ಗೆ ಜನ ಇಲ್ಲ. So human resource ಗೆ if we can pitch in, that is where something which we can help. Number 1, oxygen is a need. Concentrators agli, cylinders agli, if we can procure and give it to people, that's another thing. Give it to hospitals rather than giving it to individual homes. NGOs is also a good bet. So ಈ ತರ ಈ ಕಡೆಗಳಲ್ಲಿ ಕೆಲಸ ಮಾಡಬಹುದು ಅನ್ಸುತ್ತೆ ಸರ್.
Thank you, Doctor. I can see Manjula has raised hand, and Rajiv also wants to speak.
Okay, see, compared to the last wave, the second wave has got more mortality. It seems so. But you are saying the mortality has remained the same, and we see more
mortality. Okay, sir.
And we see more number of even pregnant people and children are affected in the second wave, which was unlike the first wave. And what I see is, you said there's literally lack of oxygen beds and ICU beds in Bangalore.
Sir, yes.
And one more is, the R0 is definitely more this in the second wave than compared to the first wave. Because earlier,
Agree, sir.
earlier we used to see 1 or 2 in the family. Now, if one comes, the whole family is having the
Yes.
positive.
Yes.
And
Yes.
one more is regarding the genomic sequencing. Are we doing an regular genomic sequencing in Bangalore?
Regular genomic sequencing is happening, sir, and it is happening in a sample because sequencing is a tough ask, and we have very limited resources for that. And genomic sequence, there is a cell and there is a nodal officer, and it is happening in NIMANS and National Institute of Virology lab within Bangalore. So one. Second, yes, R0 is higher this time compared to the last wave. That is where I told transmissibility is higher in this current strain compared to the last wave. 2. And 3, yes, it is known in a pandemic situation, in a second wave, it will affect the people who were not affected, and the demographics will also change. That is where I said third wave will mostly affect children, because they are the ones who will not be protected with vaccinations. So earlier it was elderly who were more vulnerable and faster getting infected. They also got it in population or middle-aged individuals who were roaming around. One of the reasons why we were not very strict in the first wave in terms of lockdown, so people movement ಸ್ವಲ್ಪ ಬಿಟ್ವಿ ಯಾಕೆ ಅಂದ್ರೆ we wanted the middle-aged and the young to get immune and then provide protection as herd immunity. But with mutation, vaccine escape, immunological escape, idrinda somehow mutation intadrinda that herd immunity has not worked for the second wave. So ee tara ella agirodrinda it is bound to happen that pregnant women, lactating women, ಮತ್ತು elderly ಗಿಂತ younger age group getting affected. This was known, and this is how the epidemic will progress. So third point ಏನಿತ್ತು, yes, transmissibility ಜಾಸ್ತಿ ಇದೆ. R0 more this time because ಒಂದು are known to be the transmissibility is high ಅನ್ನೋದು we know that, sir. We know that.
Manjula, Dr. Manjula wants to speak, I think.
Yeah, may I? Yeah, thank you. So,
Yeah, go ahead, Manjula. Yeah.
Dr. Pradeep, good evening, and it was a very good talk. I mean, a lot of details which we ourselves don't understand in the government. For example, the Covishield has benefit against these mutants and that's a good thing. We get to know some new things also. Now, I'm actually in charge, and then my practical problem is this first wave we were very good in quarantining, and actually we were every case to case it was very pretty strict. But
Yes.
now the number of cases going like this, is there any point in identifying contact, because we are not able to quarantine them anymore like in the past? So should we do this, or what is the way ahead? And my second question.
Yeah. Sorry. Go ahead, please.
Second wave, we should have probably spruced up our oxygen, other things, infrastructure nodkobekagitu, oxygen, etc. nodkobekagitu. Everything is being said now after realizing that we have deficiency in areas. So what do we do for the third wave now? What do you think we should plan ahead, because you're anticipating sometime in the November anta helta idira? So what do we do?
Yes.
Third questions.
Yeah, thank you, ma'am. First one, Ega at this juncture, contact tracing, quarantining, idella is a difficult proposition. Honestly speaking, that's my personal take. When we look at true epidemiological sense or science, one, because according to me, although I am talking to you off the record, according to me, there is already this community transmission. Phasally, there is no point in contact tracing, and it is the people who need to take control of their lives and do it. But when it comes to large congregations of people like apartment complexes, so slum areas, so inta kade still isolation, quarantine, contact tracing should be done, and that is where the whole, it is a time bomb in the waiting if you allow it to spread there. So alli ಮಾಡೋದು Utma, and it needs to be continued. Second thing, more reliance on testing is something which should be avoided now. ಅದಕ್ಕೆ ಜೀವನೂ ಬಂದಿದೆ to employ a syndromic approach, not wait to treat the patient until the test results come. Because now the average, last week it was higher, average turnaround time was 50 hours. Now it is about 30 hours. So early tankano, they might progress to severe acute respiratory illness tara agbittu problem agi, there were mortalities. So we are not depending on testing. So it is better to get into treatment right away. So people who they themselves are getting into treatment. So that is the way we have to look at. According to me, contact tracing, quarantine villa, as of now will not, as of today at this phase, will not yield much help. It will be waste of resources according to me. But as a government, we should not be saying this, or we could not be saying this, because it will draw a lot of media air. People might panic more. So that's one of the reasons why we are still maintaining this contact tracing and quarantine, and there is some amount of seriousness instilled onto people who do this. So second question was on how do we prepare for the third wave? Madam, whatever the second wave preparations ideo, I think that would be enough, because as far as our mathematical modeling or our epidemiological knowledge goes, it will be lesser. The number of cases. One main reason would be the war footing vaccination drive, which will happen soon. And in the next 3 to 4 months, lot of people who can bring infection home will be vaccinated, number one. Two, children, although if they get infected, it will be mostly mild. And we have to, in terms of preparation, look at pediatric ICUs, pediatric oxygen beds, and sprucing up pediatric beds, or have a contingency plan for converting the beds available, which are adult beds, into pediatric beds as soon as we see cases start raising. So that is something which we have to look at. And Neo governmental irodrinda, what I personally feel, and also most of the TAC members feel, is TAC recommendations could have been taken more seriously, at least for the third wave. We delayed this lockdown or getting preparation for about 2 to 3 weeks lag itto. Instead, 1 to 2 weeks lag idre, it would have been much more easier. But I don't think the number of cases would have reduced. Lockdown on 2 vara munche madidre, as we suggested, it would have been much more fruitful. Either though we had recommended as a TAC, you will also remember 100% cinema ella close ಮಾಡಿ ಅಂತ. But ಅದು ಪಾಪ pressure ಇಂದ business economy ಅನ್ನೋದಕ್ಕೆ it was done. That's also justified in a way, but this could have been prevented. I am not blaming any system or anything. Nano as a TAC member, I will only see epidemiology in public health. Sitting in that chair as a government, you will also have to see economy, people's lives. And I also agree that lockdown was not an option until recently, because people would die more of hunger or loss of economy rather than COVID anta namdu iddiddu. So that is something which we have to cautiously tread on. And ಬೇಗ ಹೇಳಿದ್ರೆ ಥರ್ಡ್ ವೇವ್ ಬರುತ್ತೆ, ಹುಷಾರಾಗಿರಿ, ಮಕ್ಕಳನ್ನು ಹುಷಾರಾಗಿ ನೋಡ್ಕೊಳ್ಳಿ ಅಂತ ಮುಂಚೆನೆ ಶುರು ಮಾಡಿದ್ರೆ that would help a lot ಅಂತ my take on it, madam.
Thank you.
Thank you, Dr. Santosh. Want to speak, probably? Santosh?
Yeah, hi, Dr. Pradeep, thank you. I'm Santosh Anta, UK lidini, GP ivaga. Previously, I have worked in the first line as a COVID as well, and illi iddaga public health allo, even today I work as a triage in the COVID, and quite first hand involved with public health in COVID management. It's basically ಸ್ವಲ್ಪ ಎಕ್ಸ್ಟೆನ್ಷನ್ ವಾಸು ಕೇಳಿದ ಕ್ವಶನ್ಗೆ ಅದರಿಂದನೇ ಪ್ರೊಜೆಕ್ಷನ್ ಕರ್ನಾಟಕ ಅಂಡ್ ಬೇಸಿಕಲಿ ಟೌನ್ಶಿಪ್ಸ್ ಅಥವಾ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಪ್ಲೇಸಸ್ ಕ್ವಶನ್ ಇತ್ತು. Is there any plan to publish these projections, basically Bangalore state-wise or district-wise, let's say? One question. Second, because that definitely helped us. I'm talking from my personal experience. In the regional public health non-involved ಆಗಿರೋ public health ಅಲ್ಲಿ emails ಬರ್ತಾ ಇತ್ತು ಪ್ರತಿ even primary care ಗೆ. That projections changed the game. Vaccination programs here are in a way dependent on the projection, the pattern, the demography. So if that has a huge impact here, I think at least state-wise or district-wise may have an impact. ಅದು ಪಬ್ಲಿಷ್ ಮಾಡೋಕ್ಕಾಗತ್ತಾ ಆ ಥರ ಏನಾದ್ರು ರೆಗ್ಯುಲರ್ ಬೇಸಿಸ್, ವೀಕ್ಲಿ ಬೇಸಿಸ್ ಆ ಥರ ಒಂದು. ಇನ್ನೊಂದು ಅಗೇನ್ ವಿತ್ ದ ಡೆಮೋಗ್ರಫಿ ಎಪಿಡೆಮಿಯಾಲಜಿ ಪ್ಯಾಟರ್ನ್ ಇಂದ to the west, to the India ಏನಾದ್ರು ಲಿಂಕ್ ಇದೆನಾ? Can you predict the behavior? Can you predict the symptoms? Can you predict the severity so that there can be any impact on the preparation? Thank you.
So first question, in terms of projection, no, it's a double-edged sword, sir. If we publish, people might get into this panic mode and start hoarding things. ಇದೆಲ್ಲ ಆಗ್ಬೋದು ಒಂದು.
Sorry, sir. I think I knew, so I just wanted to react. But I wanted to say that, but what you said in the beginning was slightly different. You see, you said that it's already started plateauing in some states and then it started downfalling in a couple of states, which itself is a huge positive for us. So if
Yes.
that kind of projection comes out, it might actually have a positive impact, alva?
Oh yes, it definitely has a positive impact. But in India, ಏನಾಗ್ತಿದೆ ಅಂದ್ರೆ sir, projections now we are utilizing to preparation, we are utilizing to guide science. We are not getting it published. Two reasons. One, though, ICMR has some kind of an unwritten rule, or we have kind of accepted that ICMR needs to publish this. There are published articles in terms of projections and other things, which is coming. I think in the next 2 weeks, ICMR, there will be 1 or 2 projection related articles which will come up. And as you told, ಬೇರೆ ಸ್ಟೇಟ್ಸ್ದು ಇದನ್ನ ಪ್ರೊಜೆಕ್ಷನ್ಸ್ನ ಅವ್ರು ಹೆಂಗ್ ಪ್ಲಾಟೋ ಆಯ್ತು ಅದನ್ನ ನೋಡ್ಕೊಂಡು ದಟ್ ಈಸ್ ವೇರ್ ಆ ಮಾಡೆಲ್ನ ಸೂಪರ್ ಇಂಪೋಸ್ ಮಾಡಿಕೊಂಡು ಕರೆಂಟ್ಲಿ ನಾನು ಏನು ಪ್ರೊಜೆಕ್ಷನ್ಸ್ ಹೇಳಿದೆ ಫಾರ್ ಕರ್ನಾಟಕ, ಇಟ್ ವಾಸ್ ಬೇಸ್ಡ್ ಆನ್ ದಿ ಸೂಪರ್ ಇಂಪೋಸಿಷನ್ ಆಫ್ ದೋಸ್ ಮಾಡೆಲ್ಸ್, ಕೇರಳ, ತಮಿಳ್ನಾಡು ಅಂಡ್ ಮಹಾರಾಷ್ಟ್ರ ಮಾಡೆಲ್ಸ್. The Western countries look at treatment patterns, mutations, ಎಲ್ಲ ನೋಡಕ್ಕೆ we do it. But ಏನಾಗಿದೆ ಈಗ ಅಂದ್ರೆ there are not many people to sit and write. Everybody is working, everybody is doing. ICMR is publishing it, although not in international journals, but it is being published in IGMR. Last 1 year ಅಲ್ಲಿ if you see IGMR you will see lot of projection related second wave related projections ಇದೆ. ಈಗ in next 2 weeks ಅಲ್ಲಿ there are about 2-3 papers which I know of. ಆಮೇಲೆ Lancet ಅಲ್ಲಿ there is one coming up soon which is already accepted. I don't know when it is. ಈಗ it is under embargo, so I can't tell you what the findings are, but it was confidentially circulated with the tag. And ಇದೆಲ್ಲ ಬರ್ತಿದೆ sir, publications are happening, but public domain ಅಲ್ಲಿ and I understand that it is prudent for the system to have that hesitancy also, because we don't know how people are going to take it.
Okay, sir. Thank
So
you.
second question ಗೊತ್ತಾಗ್ಲಿಲ್ಲ sir. ಮರ್ತೋಯ್ತು.
Well, no, I think you also already answered. The second question on the same line I was asking, then you Western countries ಅಥವಾ South African pattern ಏನಾರ predict ಮಾಡಕ್ಕಾಗತ್ತಾ epidemiologically, so that in the target is trying to prepare administratively prepare
Yes.
ಮಾಡಕ್ಕಾಗತ್ತಾ?
Yes, and easily I think government will focus on the third wave and how it needs to be handled. But at the same time, second wave is also, honestly speaking, ಹೆಂಗೆ ಅಂದ್ರೆ ನಮ್ಮ projections were ಸ್ವಲ್ಪ lower, about 10% lower than what we expected. ಅಂದ್ರೆ ನಮ್ಮ projection 10% ಕಡಿಮೆ ಇತ್ತು. Actually happening is actually 10% more. So that is where we kind of not very this thing, honestly speaking. But however, people panic, oxygenated beds in the hospital, idella have added on to the problems which we are seeing now. And as a country, you know, we are a very diverse, 140 crores and 140 minds, 140 ways of thinking and perspectives. It is very difficult to handle the way it is being handled elsewhere. That's also something. Within Karnataka, namge 30 ತರ ಡೈವರ್ಸಿಟಿ ಸಿಗುತ್ತೆ. ಮಹಾರಾಷ್ಟ್ರ ಕೇರಳ ಲೆಕ್ಕಕ್ಕೆ ಇದನ್ನ ತಗೊಂಡ್ರು ಕಷ್ಟವೇ. ಇನ್ ದ ಸೆನ್ಸ್ ಮಹಾರಾಷ್ಟ್ರಕ್ಕೆ ಸ್ವಲ್ಪ ತಗೋಬಹುದು ನಾರ್ದರ್ನ್ ಕರ್ನಾಟಕ, ಬಟ್ ಕೇರಳ ಮಾಡೆಲ್ನ ನಾವು ಇಲ್ಲಿ ಉಪಯೋಗಿಸಕ್ಕೆ ಆಗಲ್ಲ. ಸೊ ದೋಸ್ ಆರ್ ದ ಥಿಂಗ್ಸ್ ವಿಚ್ ಕಾಂಪ್ಲಿಕೇಟ್ಸ್ ದಿ ಇಶ್ಯೂ ಆಸ್ ವೆಲ್. ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಪ್ರಿಪರೇಷನ್ ಆಗತ್ತೆ. It complicates things. That's how it works.
Thank you, sir.
Thank you, Doctor. I have Umakant Adiga who wants to share something. Umakant, you can go ahead.
Yeah. Hello, Dr. Pradeep. No, Dr. Umakant. I'm a pediatrician. I've been also working with step 1 from past 1.5 years.
Yeah.
ನನಗೆ ಒಂದು ಕೇಳಬೇಕಿತ್ತು. This is regarding the ಕೇಳಿಸ್ತಿದ್ಯಾ?
ಕೇಳಿಸ್ತಿದೆ ಸರ್. ಸ್ವಲ್ಪ ಲೋ ಇದೆ ವಾಯ್ಸ್ ಅದಕ್ಕೆ.
ಓಕೆ. First wave ನಲ್ಲಿ the maximum number of cases were around 11,000-12,000 in Karnataka, if I am correct. ಈಗ second wave ನಲ್ಲಿ it can go up to 60,000 ಅಂತ ಹೇಳ್ತೀರಾ? Possibly it can go.
ಕರ್ನಾಟಕ ಅಲ್ಲ ಸರ್?
ಕರ್ನಾಟಕದಲ್ಲಿ. So assuming that 5% of these people will need HDU or oxygen beds ಅಂದ್ರೆ how can we manage in the coming days? 5% of 60,000 ಅಂತ ತಗೊಂಡ್ರು ದಿನಕ್ಕೆ ಒಂದು 3,000 people are coming who requires oxygen. How are we going to handle it? Because one patient on oxygen bed occupy ಮಾಡಿದ್ರೆ will be there for about 5 to 7 days, sometimes 10 days. So how are we going to manage this huge problem in the coming days?
ಸರ್, ಈಗ ಏನಾಗ್ತದೆ, almost 50% of available beds are oxygenated. Okay, sir. And we have around 14,000 beds ಅನ್ಸುತ್ತೆ. I am not very sure. It may be anywhere between 14 and 20,000 across Karnataka. So adral 50% of the beds are oxygenated already. So 60,000 bandrunu oxygenated beds are there. The question is availability of oxygen is the thing. So it should ease out in the next 1 week or so, sir. So we are in a way well prepared in terms of oxygen. And hopefully we will be able to sustain it, sir. 3,000, we have 10,000 oxygenated beds. If we can organize oxygen, that is where we win this game. So that has been organized. The system is very, very proactive, sir. I have seen in close quarters, not within the system, but as an external TAC member, although I work with the system, ಮೇಲ್ನೋಟಕ್ಕೆ ಹೊರಗಡೆ ದೇಶಕ್ಕೆ ಕಾಣಿಸೋಂಗೆ it looks very haphazard and 60,000 looks very high, but when compared to 7.5 crores, 60,000 is in terms of proportions low. But ಅದನ್ನ ಒಂಥರ ಮೀಡಿಯಾ ಪ್ರೊಜೆಕ್ಟ್ ಮಾಡೋದು ಇದೆಲ್ಲ ಒಂಥರ ಏನಪ್ಪಾ ಅನ್ಸುತ್ತೆ. If we can triage people well, we can judiciously use the beds available. That is my take. And triaging there will be strict idu. And sarre gottirutte. There are IPS officers, there are IAS officers who have been deputed as nodal officers in each zone of Bangalore to manage this kind of ruckus created by citizens. So ಆಗ್ತಿದೆ sir, it is happening. And ಏನಂತಾರೆ ಅಂದ್ರೆ ಯಾವಾಗ್ಲೂ in terms of thinking, a thief is always ahead of the police and hangge. The virus and the community psyche is always ahead of what we think as scientists and managers within the system. That is how I read this situation. So beds ide sir, no problem anta nan prakara. And oxygen triaging is where we have to make people learn or understand. That is the focus, which would be the focus for the next 1 or 2 weeks, sir.
Okay, sir. Thank you. That's very reassuring to hear that
Thank you, sir.
people are working
Thank
in
you,
more footing.
But I think third wave pediatric beds, pediatric oxygenated beds is something which needs to be looked at, and
It's
that
not
will be
only-
looked at, sir,
It's
definitely.
not only the beds, it's the manpower, because entire Bangalore,
Manpower,
I
adu
think hardly
we
there
don't
are
know
a few
ಸೃಷ್ಟಿ
PICUs.
ಮಾಡೋದು ಹೇಗೆ ಅಂತ we don't know. But ಏನ್ ಮಾಡಿದೀವಿ ಈಗ final year MBBS ಎಲ್ಲ have been roped in. Some of them say it is not good anta, but something is better than nothing, and under supervision they could save a lot of lives ಅನ್ನೋದು ಅಭಿಪ್ರಾಯ. So ನೋಡ್ಬೇಕು sir how things will be managed ಅಂತ.
Okay, sir. Thank you.
Thank you, Doctor. I think Shivana has a question to ask. Shivana, go ahead. Switch on your mic, Shivana. It's
Okay,
muted.
can you hear me? Hello.
Yes, Shivana.
Hello.
Yeah.
ಕೇಳಿಸ್ತಿದೆ sir.
Thank you, Subbu. Thank you, Dr. Pradeep. I've got 3 questions. When can we expect this oxygen shortage issue be sorted out? Is the first question. And people are hoarding oxygen at homes. Did you advise that, or you are against that? Second thing, you mentioned about starting ICUs in medical colleges, particularly the new private medical colleges. Is there enough expertise to manage this in those medical colleges? And is there anything being done about the manpower in those colleges? And third thing is, as you rightly pointed out, the mortality is very high on patients going on ventilators. But in reality, what we see, even in my own hospital, where it's Apollo Hospital, Bangalore, we have got less number of non-invasive ventilators compared to ventilators. I personally think there should be at least for every 1 ventilator, there should be 3 or 4 non-invasive ventilators in this current COVID situation. So do you think that stress should be given to HDUs with more of non-invasive ventilators than ventilators, and try to prevent patients going on ventilators? Because many of the patients, if we can help them with their oxygenation for 2 to 3 days in those critical periods, we can prevent them going on ventilators. So is there any thought about more of NIVs than ventilators, sir? Thank you.
Yes, sir. More NIVs, that is the current thought. We just had a marathon 3-hour meeting on establishing 500 ICU beds in Bangalore and about 1,500 across Karnataka. What we suggested as a technical advisory team was to establish NIVs than ICUs. One, because COVID situationally, ICUs are not that much helpful, and it won't be a cost-effective way of looking at it.
Exactly. Yeah.
Because resources, specialist resource is something. But medical colleges, we can rope in physicians, we can rope in anesthesia, we can rope in pulmonologists, we can also rope in other specialists like CTV surgeons, cardiologists, endocrinologists to an extent. Elrunu ಮಾಡಿ, if they can be supervised, ಬೇರೆ ಈಗ ENT ಆಗಿರ್ಬೋದು, ಆಮೇಲೆ anatomy, physiology, they are basically MBBS doctors who will be practicing somewhere. If they can be put into medicine wards, and physicians can be put into ICUs and made to manage NIVs, then it would prove something we have to plan out, and we are trying to come up with a plan. Oxygen situation ಯಾವಾಗ ease out ಆಗುತ್ತೆ ಅಂದ್ರೆ in the next 1 to 2 weeks it should ease out, sir. The oxygen issue ಏನಾಗ್ತಿದೆ ಅಂದ್ರೆ patients who do not require oxygen are also receiving oxygen.
Exactly.
ಅದನ್ನ ಕಡಿಮೆ ಮಾಡಿದ್ರೆ ಎಷ್ಟೋ ಉಳಿಯುತ್ತೆ ಸರ್. ಈಗ ಜುಡಿಷಿಯಸ್ ಯೂಸ್ ಆಫ್ ಆಕ್ಸಿಜನ್ ಬರ್ತಿದೆ. ಯಾಕಂದ್ರೆ ಆಕ್ಸಿಜನ್ ಸಪ್ಲೈ ಕೆಳಗಡೆ ಸ್ಟೋರ್ಸ್ ಅಲ್ಲಿ ಪ್ರಾಬ್ಲಮ್ ಇದೆ ಅಂದಾಗ ಫಿಸಿಷಿಯನ್ಸ್ ಲುಕ್ ಅಟ್ ಇಟ್ ಆಸ್ ಇವನಿಗೆ ಕೊಡ್ಬೇಕಾ ಬೇಡವಾ ಅಂತ ನೋಡ್ಕೊಂಡು ಮಾಡ್ತಿದ್ದಾರೆ. ಅಲ್ಲಿ ಒಂದು ಕರೆಕ್ಷನ್ ಆಗುತ್ತೆ. ಸಪ್ಲೈಸ್ ಆರ್ ಆಲ್ಸೋ ಇನ್ಕ್ರೀಸಿಂಗ್. ಸೆಕೆಂಡ್ ಕ್ವಶನ್ ಮರ್ತೆ ಸರ್, ಫಸ್ಟ್ ಅಂಡ್ ಲಾಸ್ಟ್.
I think that there are new ICU that has been started in medical colleges, expertise, but which you answered. I think.
ಎಕ್ಸ್ಪರ್ಟೀಸ್ ಇದೆ ಸರ್, ಅಂದ್ರೆ ನಾಟ್ ದಟ್ ಮಚ್. ಈಗ ICU ಇಂಟೆನ್ಸಿವಿಸ್ಟ್ ಟ್ರೈನಿಂಗ್ ಇರ್ಲಾರ್ದು, ಬಟ್ ದೇರ್ ಈಸ್ ಈಗ ಏನಾಗ್ತಿದೆ, ದೇರ್ ಈಸ್ ಟ್ರೈನಿಂಗ್ ಹ್ಯಾಪನಿಂಗ್.
Yeah, because if you see even in our own government medical college, I don't want to name them, the mortality is so high when patients go on the ventilators in these government medical colleges. So the same thing, I have heard about few private medical colleges, there is absolutely no expertise, and this is what we have heard. So if we can rope in, probably we may have to rope in from other sources. I'm not sure about that.
Right.
And
it is international data, sir.
Yeah.
ICU hodre the mortality is almost 70 to 80%.
That is where the role of non-invasive ventilators and even to modify, improvise the vein circuit with a non-invasive mask itself will be so much efficient, because to get even an NIVs will be difficult, but vein circuit with a non-invasive mask will definitely give the patients easily 12 to 24 hours of time.
I completely agree, sir. NIV is what saved me personally.
Yes, absolutely.
And as a doctor, I staunchly refused going in for mechanical ventilation, even though my friend suggested you should go in. I said nothing doing until I fall unconscious. Don't put me on a mechanical ventilator. And sir, respiratory therapists yaridare, physiotherapists, they also play an important role. And if we can train them, train our MBBS students to do that, interns to do that, final year MBBS, that will save a lot of people also, sir.
I just want to, I don't know, many of my friends are not aware of this. Our family, 3 of us, all family, me, my wife, and my son, just are recuperating from the same COVID, and we did the same thing with all these prone ventilations, prone as breathing exercises and stuff. Luckily, we just we never needed the admission of hospital.
Congratulations, sir, and you are a true warrior. I know how it is when everybody in the family is infected. It's not easy being a doctor when you know a lot of things around you. So it's very difficult. Not just the media, thorough knowledge of things around.
Thank you.
All the best, sir. All the best. Nice.
Thank you. Nice talking to you. Thank you.
Thank you, Dr. Pradeep. I think next we have Dr. Kalayadav.
ಇಲ್ಲ ಸ್ವಲ್ಪ ಬ್ರೇಕ್ ಆಗ್ತಿದೆ ಅನ್ಸುತ್ತೆ.
And she'll be speaking. Dr. Kalayadav, go ahead. You can switch on the mic.
Can you hear me?
Howda?
I can.
Yeah, audible.
Thank you, Subbu, for the opportunity, and thank you, Pradeep. That was a very nice presentation. I'm Dr. Kalayadav. I'm one of the nodal officers for RT-PCR lab. So one of my question is, in some of the PNDSM books very long back, we have read a point which says that vaccination during the peak of pandemic may not be a very ideal situation, because as it is, the virus is everywhere, everybody's inhaling it, we're all getting exposed to it. So is vaccination really effective during the peak of the pandemic? That is one thing. And second thing, what we're seeing is most of the patients which I have come across, they've had a dose of vaccine, third or fourth day after the vaccine, they're turning out to be positive. And the question is, following vaccination, is there a drop in immunity and then they're acquiring because of the pandemic and then becoming positive? This is my first question. Second one, coming to children, because as you said, third wave is going to be children. So that is going to be even more devastating, because losing children will be very bad. But what I'm seeing now is, because of the peak in the second wave, everybody in the family is becoming positive. That means most of the children are becoming positive. Thank God they're all in the mild symptoms. Only the elderly is affected with moderate and severity. Now, how do you suggest? Because what I am seeing in my lab is, I'm getting newborn babies swabs to be tested, who are born to, during labor, or who are born to positive mothers. And some of them we are giving them as positive, as positive for the newborn babies. Now, if the children are affected in the second wave, how is it going to make a difference in the third wave? And if you suggest vaccination for them also, what should be the the difference? I mean, after they have acquired the disease and they've come out of it, is there a span that you have to give, or do you really suggest vaccination if they're
Yeah. Madam, in terms of vaccination to children, currently there is no evidence. So vaccination as of now is not recommended for children. Two, in terms of children who get infected in the second wave, they are going to be our kind of saviors or kind of shield for other children not to get infected. But it depends on how many children get infected. So that is unlikely to have about 40 to 60% of them children getting infected. And in terms of mortality among children, it will be very, very, very low. Not as much as we are seeing now or in the elderly. But we have to be careful. And I know it's not just losing children, the sentiments across, not just from the family, but also from the community and the media. It's much more emotional when we lose children rather than when we lose somebody who is an 80 or a 90-year-old. So that way we have to be really, really cautious and be really well prepared. And that's something which the government has already started thinking. And that is something which will be seriously taken up.
Because we don't have pediatric ICUs.
Yes, pediatric ICUs is something which we have to be equipped with as well. So second thing is post-vaccination positivity is a known phenomenon. And in the current pandemic, it is very difficult to kind of say whether it is because of the vaccine or it is because of true infection. And the guideline is not the guideline. The thumb rule or by convention, it is better for them to be treated as a pediatric COVID case, vaccine as a natural COVID case is being treated in terms of looking at symptomatic as well as doxy and ivermectin as well. So third question was, Martode madam, first question.
Should the children be vaccinated in future?
Yeah,
I mean, if they are positive.
No, as of now, not recommended. Reason being there is no evidence. And there are a lot of ethical issues and other things to start vaccinating children as part of a trial. So that's something which currently there is some evidence.
It may not happen in the next 2 to 3 months also. The children will not be vaccinated for the third week. That is what is going to be expected.
If you trust my epidemiological or public health knowledge, my answer would be no.
So children are going to get natural immunity only.
They should be, otherwise there is no other way, because there are a lot of ethical issues involved in having a trial for children. So very difficult. I'm not sure whether there are any trials going on. I'm not sure. I stand corrected as well.
So anybody less than 18 years will not be vaccinated. That is right?
Yes. No, they won't be vaccinated.
And you suggest that we continue vaccination during the peak of the pandemic. There is no issues with that.
Yes.
Because I don't know, a friend of mine just put in a word. He was telling that, just when a few microbiologists were talking, this could be very funny, but she was like, see, the body is already getting 2 strains. One is you're already getting a wild strain, you're inhaling it. And on top of it, you're being dosed with a vaccine strain. So 2 strains entering the body itself can act as a carrier for 2 strains which can mutate. I don't know how far this is true. So she said that could.
Yeah. There will be some amount of what we call as vaccine or immunological escape. But when we look at the benefits and the risk, benefits outweigh the risk in this current COVID situation, 1. 2, the PSM book reference which you made, was specifically for polio and provocative poliomyelitis. And epidemiologically speaking, it is possible there might be some cross mutation and things like that. But in terms of the current vaccine, which is a spike protein, and looking at virus materials, having both natural infection and viral particles will in a way be cumulative. That is what the literature says. We have not tested as of that particular question is concerned within India. But literature says it should not be a problem. But there is this phenomenon of immunological or vaccine escape, which is bound to happen, but that is very minimal. That gap could be organized. Is not a problem considering the number of cases which we are looking at. And vaccination is the only answer to reduce or make the third wave mild.
Yeah, thank you, Pradeep.
Thank you, ma'am. Thank you.
Thank you, doctor. If you still have patience, we have around 5 of our classmates who have raised hands. I'll go ahead if you're okay with that.
Oh, yes, I am available, sir. No problem. Please continue.
Syed is, I think, has been waiting for a long time. I'll take Syed and then Umesh and Bhagesh.
Hi, Syed. We have been childhood friends for long.
Really?
Hi, Syed.
Hi. You're talking about Syed, not Saeed.
Oh,
That's
okay.
Syed.
I spoke about Syed.
All right, okay. They're still brothers. So, a couple of comments. I mean, this looks like a raging forest fire, and we are all trying to use a bucket of water. But nonetheless, looking at what's happening, it's really heartbreaking. I have a couple of observations. I mean, people are in dire need of information on this disease, on its prevention, and its treatment. I mean, there are a couple of government representatives, I think, in our batch, and it was very heartening to see Dr. Manjula accepting that there were some deficiencies. What I was thinking was, and if there is a arrangement where the government person plus a medical expert come together and brief the media very regularly, then a lot of apprehensions and a lot of mental health problems and a lot of confusion can be prevented. If I'm a small person to suggest this, but it will go a long way if that happens. I mean, at least that's what we have seen here in the UK and in the US with regular press briefings on the information. The second thing is about remdesivir. Now everyone knows that it is of no use, but the government has taken control and is still distributing it. Isn't it right for the government to come out and say it's of no use? Similarly for oxygen, because as Shivana said, people are hoarding oxygen and this is causing an artificial scarcity in the hospitals and in ICUs. So if there is a government control on oxygen, I think that will also help go a long way. But we're all here are together to support how it is. I'm raising some funds to get some concentration machines. And also I'm providing some, although I'm an orthopedic doctor, I'm trying to help by providing some telemedicine, whatever I can. And that includes a few of my friends as well. But thank you very much, Dr. Pradeep, for giving us a talk. Thank you.
Thank you, Dr. Syed. In terms of, sir.
Please go ahead, Doctor.
Yeah. In terms of press briefing, it is happening, sir. Daily, Government of India has a specific time between 4:30 to 5:30, which is live in many news channels, along with there is a YouTube link also, which happens every day. And Karnataka government is also doing it. So we as stake members have offered the government to actually utilize our expertise in doing so. And time and again, we have been coming to the media and briefing through it. And in terms of information to the people, I would agree with you. But in terms of information, there is a lot of it in the internet, social media, and WhatsApp University. But what people need is correct information. But the problem with it is people don't know which is correct and which is not, and which is both of those correct or not so correct information they are not ready to believe. That is where we stand today. That is part of pandemic psychology, psyche also. So in terms of oxygen concentration,
No oxygen rationing by the government to
oxygen rationing and remdesivir also. So oxygen rationing, sir, we actually left it open earlier. But oxygen concentrators, I told you earlier, every third house has an oxygen concentrator now. And there is a demand supply gap which has created a lot of ruckus. Oxygen supply in terms of this thing, to make it self-sustained, there are liquid oxygen plants which is being organized in every district hospital. Now it is being extended to community health centers as well as taluka hospitals in the state. Private setups, they are also doing it, and things will ease out in the next 1 or 2 weeks. Remdesivir, yes. Individual physical, that is how it needs to be as long as it is saving the patient. Although at the macro level, there is very little evidence of the usefulness of remdesivir. And this is again community psyche or disaster or pandemic psyche, which is known to happen. That will all get streamlined soon, sir. But remdesivir is there because lot of clinicians believe that it helps. Lot of clinicians, out of their experience, they know that it is working, and they know on whom it works. But the problem is we don't have time to have that as data, have that as have that published. So that is where we are. It's a catch-22 situation, sir.
Thank you.
Thank you, Doctor.
Thank you, sir.
We'll take around 4 more questions. Umesh is online. Umesh, go ahead.
Oh, can you hear me?
Yeah, Umesh, go ahead. You're audible.
Yes,
Yeah,
sir.
so, Dr. Pradeep, thank you for the excellent talk. My first question is about streamlining of the available beds. Can we do something like issue guidelines to the hospitals, and like a particular, this is what the criteria that should be satisfied for this patient to be admitted? Can that happen from the government and somehow enforce it? So that, this is the problem that I have personally, I'm sure he has been facing in the last few days, that people are running from hospital to hospital looking for beds. That's one thing. Secondly, the availability of paying beds in the private hospitals. Is there a resource which can give us information, real-time information about availability of beds? The BBMP is doing an excellent job. We call the helpline. They do help us out and direct us to a proper hospital. But the situation is not the same with the private hospital bed availability. Is there a resource where people can go to find out where bed is available? That's one thing. Other thing is, do we have enough evidence in favor of doxycycline and ivermectin? Do we use them in every patient? Should we use them in every patient? Because we are not as of now, at least at our hospital.
Yes.
Yeah, so I'll have just these 2 questions here.
Okay, sir. In terms of bed availability guidelines, bed allocation guidelines, there are guidelines, and it is being very well followed by BBM, I can assure you. And that is something which is made available. So the current bed issue was because private hospital beds were not allocated for BBMP till last week or so. And that is being streamlined now, and that is happening. In terms of private beds in private hospitals, there is a real-time app which is coming up from the private hospital network. I think Fanano, the organization or association is there. Alinda, it is getting ready. sometime this week or next week it will come ಅಂತ ಹೇಳ್ತಿದ್ದಾರೆ. They said last Thursday it would come up, but it hasn't come up yet. They just said next week anta. So it will come up soon. Bed availability in private hospitals, and that is completely out of their association themselves. And last year ಏನಾಗಿತ್ತು, those hospitals more than a minimum number of beds have to allocate 50% ಅಂತ ಏನ್ ಹೇಳಿದ್ರು. ಈ ವರ್ಷನೂ ಅದೇ ಗೈಡ್ಲೈನ್ ಇಟ್ಟಿರೋದಕ್ಕೆ ಲಾಸ್ಟ್ ಇಯರ್ ಏನ್ ಮಾಡ್ಕೊಂಡಿದ್ದಾರೆ, ಕೆಲವು ಪ್ರೈವೇಟ್ ಹಾಸ್ಪಿಟಲ್ಸ್ ಅವ್ರ ಬೆಡ್ಸ್ ನ ರೀಅಪ್ರಾಪ್ರಿಯೇಟ್ ಮಾಡ್ಬಿಟ್ಟು ಆ ಮಿನಿಮಮ್ 50 ಅಂತಿದ್ರೆ ನಮ್ಮ ಹತ್ರ 48 ಬೆಡ್ ಇಟ್ಕೊಂಡಿರೋದು ಅಂತ ತೋರಿಸ್ಕೊಂಡು ಕೋವಿಡ್ ಲೆಕ್ಕಕ್ಕೆ ಡಿಸ್ಟೆನ್ಸ್ ಮೇಂಟೈನ್ ಮಾಡಿಕೊಂಡು they have reduced the number of beds, and that is where it is difficult for BBMP to allocate beds there also. That's part of the game. That is how it works, and that's not wrong also. So idu BBMP beds private beds lekkake. What was the third question, sir? Again I forgot.
The doxycycline and ivermectin. Doxycycline
there is evidence, and it is a national protocol now, sir. There is evidence. I think ivermectin is kind of a game changer, as I told you earlier. Doxy as well. ಎಷ್ಟೋ ಜನ ಈಗ azithromycin ಮರ್ತ್ಬಿಟ್ಟಿದ್ದಾರೆ. Doxy ivermectin is part of the home isolation guidelines also, sir. ಈಗ
No azithromycin, no hydroxychloroquine.
No, HCQ ಅಂತೂ ಇಲ್ವೇ ಇಲ್ಲ. ಬಟ್ ಕರ್ನಾಟಕ ಹೋಮ್ ಐಸೋಲೇಷನ್ ಗೈಡ್ಲೈನ್ಸ್ ಅಲ್ಲಿ ಕಾಂಟ್ಯಾಕ್ಟ್ಸ್ ಆಫ್ ದೋಸ್ ಟೆಸ್ಟೆಡ್ ಪಾಸಿಟಿವ್ ಗೆ HCQ ಕೊಡಿ ಅಂತ it is still there in Karnataka guidelines.
Okay.
Thank you, Doctor. I think Dr. Seema is online, and Seema, you can go ahead. Your mic is on.
Okay. Thank you, Dr. Pradeep, for such a useful talk and for all the information you have given. I am a family medicine doctor. I practice in the US, so I do a lot of outpatient COVID care. And one thing that that we have been using in the US that has been shown helpful. Of course, it is to prevent if you think that someone is going to go into a serious progression to needing ICU care, or if you predict that then we give monoclonal antibody infusion within 4 or 5 days of patient testing positive and being very symptomatic. I was just curious if there has been any sort of collaboration or anything like that has come into your purview at this time, or something like that coming up in India, at least not for now, but for the future, availability of those.
Yeah, as far as my knowledge goes, nothing of that sort as of now in India, but plasma used, convalescent plasma. Monoclonal antibodies, I am not very much aware of it, so I'm not sure about it. Yes.
Okay. Yes, I'm aware. Yeah, certainly, I'm aware that it is not yet being used. Here, I'm seeing a lot of my patients outpatient care when they have mild disease yet. But if they have severe COPD, severe OSA, chronic respiratory failure, or if their basically their profile indicates that they will be the ones who would end up being hospitalized and may progress to needing ICU care. We are doing antibody. Again, this is anecdotal data from my practice, but we have been very successful in preventing a lot of hospitalizations because same thing, we were having problem of having beds and manpower when at our peak. So it helped a lot to have that. So it's expensive therapy, but has been very useful in preventing a lot of deaths in my opinion. But again, if that would be collaborated with the larger pharmaceuticals and mass produced in India, of course, it's right now not being produced as much even here. So just a thought. That was the first one. Second thing is one of our colleagues, Dr. Prashant, works in Bangalore, and he had to leave early. He was having a question with ivermectin, doxycycline, because he cannot give that to pregnant or lactating moms. So he was asking for an alternative. Do you have any suggestion for that?
I think there are guidelines for pregnant and lactating mothers where we avoid ivermectin and doxy, but azithromycin plays a role there. One. Two, ivermectin is also used because the benefits outweigh the risk. That is where doxy for sure they are not giving for pregnant and lactating mothers as far as I know. But I think we should check with obstetricians and pediatricians.
Okay. My final, the third question that I had was with the vaccination for children. So here we have Pfizer and Moderna vaccines for Pfizer for 16 and over, and Moderna for 18 and over. But Pfizer has successfully completed the trial for 12 to 16, and they have given data to our and we're expecting it to be approved next week for 12 to 16-year-olds, 12 to 15 rather. 16 is already approved. And we are hoping that by June, we will have already start vaccinating the adolescents here. So far, the safety data and the efficacy has been very encouraging with the Pfizer vaccine. My opinion is that if we are thinking that the third wave is going to hit children harder because they are the ones who don't have the immunity, among the population, then even if it's a small percentage, that's a huge number of children who will be infected and who will need care. And also there is a problem of MISC, multi-system inflammatory syndrome, so the syndrome complex. So that is certainly a concern if we are not thinking ahead, just like how second wave, India was kind of caught off guard with this kind of increase. For the third wave, shouldn't we be thinking about vaccinating the children? Because if we think they are going to be the ones who are going to be hit, because we have to send them to school. You cannot have the children locked up forever. We need to get them back into school and have education and peer-to-peer contact. So in my opinion, if safety data starts coming out for vaccines, I really think it's prudent to think about vaccinating our children as well.
Yeah, but without evidence, it is very difficult for anybody to vaccinate children below 18 years because that's the current evidence. And it's heartening, and I feel optimistic if the Pfizer vaccine is effective and given approval by the FDA as well. Yes, there are people who are thinking about vaccinating children, but there are a lot of ethical issues and other things. So that is where maybe, I'm not sure, people are hesitant to go ahead with trials of that sort. Good that if Pfizer comes, then maybe they will try things out with Covishield, Covaxin, or any other vaccine for that matter. And definitely there will be people thinking about it within the system and the researchers as well. And but I am not very much aware about vaccination trials or programs for children as of now. Thank you.
Thank you, Doctor. I think it's closing on 11, but if you permit, I'll take two more questions. Dr. Bhagyashree is meeting, I think, online.
Yeah.
Bhagyashree, if you can actually on the mic and ask a question, you can go ahead.
Hello, sir, Dr. Pradeep. It was a great discussion, and thank you for giving your time and so much of patience in answering all our questions. Firstly, you said by everything will get regulated in 1 or 2 weeks. And at the same time, you're telling peak might reach at May 15th and we might attain a plateau by June. So what did we say is similar situation like what happened in the wave 1, where 1,000-bedded institute, this thing was in the exhibition center. It really didn't help us out. And did you anticipate this second wave to be affecting the younger generation, means 18 to like less than 60 in the first wave also? And again, we failed there. But now again, the third wave you're telling in November is going to be affecting the pediatrics and not vaccinating the kids. Are we going to invite trouble with this again? Because pediatric ICU, forget about ICU admissions. Ward admissions itself doesn't happen in India much. Pediatrics are most of the OPD admissions. So we don't have nurses. We don't have expertise to treat pediatric kids in the wards or in the hospital. So it's going to be a disaster if the third wave is going to be with the pediatrics. So what's your take on that?
Yeah. I told you that third wave is going to be there.
Yeah.
But it will be much milder and peak will be lesser compared to the second wave.
Okay.
This is based on history and our current modeling data.
Okay.
And I said more children will be affected. I didn't say more children are likely to be affected is what I said. I didn't say only children will be affected.
Okay.
So, and without scientific evidence, we will not be able to vaccinate children. Yes, I agree. If children are vaccinated, we can avoid the third wave. But current situation, without scientific evidence, we will not be able to go ahead with it because of obvious scientific, ethical, and regulatory reasons. We did know that the second wave would be higher. We did know that it will affect the unvaccinated, and indirectly that meant unvaccinated were those who were below 45 years. So that's how we expected that the youth will be affected, and mortality is similar to what it was earlier. In fact, it is lower compared to the first wave. And in the first wave, we did expect that some youth will also be, those below 60 years will also be affected, and that is how it happened. So that is how. So mortality, one of the reasons why it is low is because it is affecting middle-aged people. 2, vaccination. 3, people have started self-medication based on a lot of other information, the guidelines available in the net. They have started getting themselves treated. Of course, with a call to their own family physicians or those who know their own unknown doctors. So these are all the reasons why case fatality is very low this time compared to the last occasion. Last, it was 1.6 to 1.8%. Now, it had been up to 6% in the early stages of the epidemic. As the epidemic progressed, it came down to 1.6%. Now it is between 0.4 to 1%. So that's the kind of efficiency the vaccination has made. And 2, it is affecting the middle age who were known to be having more number of mild and moderate disease. I know vaccination of children would be an answer, but with current evidence, it is difficult. And I think Covishield is being, I'm not very sure. There is some trial ongoing with Covishield on children, but I don't know. So I don't like to comment on it.
Okay, sir. Thank you.
Thank you. Thank you.
Thank you, Doctor. We'll take the last question probably.
Yes.
Join your mic and just ask the question. Rajesh, go ahead. Rajesh, if you're still online, just respond. Okay, Dr. Pradeep, I think. Okay, Rajesh.
Hello, can you hear me?
Yeah, Rajesh.
Go ahead, Rajesh. Yeah, go ahead.
I think I need to open, man. So, Dr. Pradeep, thanks. I think you have really comprehensive knowledge of everything what's going on, and listening to the whole talk, I feel you're really up to date. And I think whatever you have spoken need to translate into what's happening on the floor. And most of the people have already asked all the relevant questions. I don't think there's nothing much to add for this. With respect to the pediatrics, being a pediatric pulmonologist in UK, we look into all these things extremely carefully. So what I can add with this is Pfizer is, we do give Pfizer vaccine above 18, as you know, and AstraZeneca, the Oxford one is eligible for children more than 16 years old. And being a pulmonologist, we have started considering some extreme cases with significant lung morbidities and everything more than 12 years old. I mean, this is only with our approval here. I thought I'll just put these points into it because everybody is asking about children here. And the trials have already started for 16 to 17 here locally. And I think there is some talks about nasal vaccine, just like nasal flu, the nasal COVID vaccine trials have started. So a lot of things have already started. And as you know, with there's so much of stringent rules with children, it's not easy to get the vaccine rolled out. And I feel the increased number of children being infected is mainly because we are testing more. Because children may have get affected and become more asymptomatic and keep transmitting around, but we are more aware of testing people now, so we test more and we see more. That's what I feel. And I think pediatric intensive care can be converted into adult ITU, which has been ongoing for a long time here. So most of the PICU got converted into adult ITU when the second pandemic happened. So I think either way, so you can use it either as an adult ITU or a PICU, whichever way you can go. I think that's my comment basically. Thank you. Thanks for everything.
Thank you,
Pradeep.
sir.
No worries.
Yeah,
This is
I
Sai.
agree with
Thank you
you.
for agreeing to do this for us.
Yeah.
Thank you, Dr. Pradeep. It was one marathon session. I think we've just crossed 2 hours now, and you've been so patient. You've never actually dismissed any question with a short answer. You were exhaustive in each answer, and I can see. I don't think you left any question unanswered. Though you had a narrow specialty, but still you were able to manage all the questions that were thrown at you. That is really amazing. I'm sure. Once again, it's 11:05 here, and a very odd day, Sunday. We probably spoiled your Sunday, taking off 2 hours, the last 2 hours of your Sunday. But anyway, thank you once again. And it was an initiation by Dr. Vasu, who's again working, as I told, on the field. And then this thing happened. Suggestion came from Dr. Sai, and one thanks to Sai from all the classmates, because when I asked you if you were willing to take the session, one thing you said was anything for Sai. So thank you, Sai, once again for suggesting Dr. Pradeep's
Thank you,
name.
Pradeep. Thank you, Subbu and Vasu.
And I think today we've got a very broad canvas on which we can actually have our closed door discussions. So since most of the answers were, questions were touched upon, and you also gave us a very, very promising picture. That was very surprising, because I thought when you said the peak would be somewhere in mid of May, we would really be facing shortages of beds or medicines and oxygen. But then you gave a very, very promising picture. That's very, very unusual, actually. That was surprising. So with all this, I think we can look forward to coordinate better. And I think our class will coordinate as your own group was doing. Many of the classmates were actually coming forward to do something, but we were not able to zero in on what exactly to do. I think this gives us some kind of a picture or some kind of a base or foundation on which to work on. So before closing this session, I think Vasu, we can close the session before.
Yeah, there are only two things. There are a lot of questions in the chat box which we couldn't put before Dr. Pradeep. Maybe we'll be in continuous touch with him in future, all of us, and we'll continue to discuss one. Second, it's not just me and Subbu. There are many people in this team, and we'll continue to organize these. I mean, after listening to Pradeep, I strongly feel that we should continue to hold such webinars. It will help not just the group which is participating here, but the larger community. So we'll definitely organize few more, and maybe we'll trouble Dr. Pradeep again. Thank you.
Dr. Pradeep, your mic is switched off.
Yes.
Yeah. Oh, thank you very much. I am available, and more than all of you, I gained a lot more people, lot more friends through Sai. So thanks to Sai and Dr. Subramanya also, and thanks Dr. Vasu, because initially Sai told that you will be contacting, but you were busy. And thank you. And we will really be in touch, and anything you just let us know, and we will also be in touch. Thank you very much.
Thank you.
Once again, thanks to all the classmates for joining in. It was more on a personal note. It was very nice seeing all the faces. Thank you.
Yes.
Thank you.
Thank you. Take care.
Have a nice
Stay safe.
weekend
Bye.
of whatever is left of the weekend. Thank you.
That too without the masks.
Yeah.
Thank you. Bye-bye.
Bye.
Thanks, everyone. Thank you.
Thanks, everyone. Bye.
Good night, all of you. Good night.
Good night, guys. Good night.
Good night.